We also have a team that will be presenting a case from, is it Mchinga or Northern? I hope they're on the call. If you're on the call, are you able to just say hello to the network?
Dr. Ziambo, is Southern Province that will be presenting.
Oh, it's Southern Province.
Yes,
all
we
right.
didn't get a case from the North.
Oh, okay. All right. So thank you, Southern Province, for coming through and joining us this afternoon. Okay, thank you very much, everyone, for coming through. Right now, I'm going to give an opportunity to the team that has joined me in the hub to just introduce themselves. Please go ahead, Dr. Natalie.
Thank you very much, Dr. Ziambo. Good afternoon, network. My name is Dr. Natalie Vlahakis. I'm the prevention lead with Insiders. And prevention's really, has a soft spot for me, as I feel that's the first line that we need to serve a little bit more than we have been in the past. So looking forward to an interactive afternoon. Thank you.
Good afternoon, team. I'm Michael Kabongo. I'm a medical doctor. I'm Insiders under Proud Z project. We support the Lusaka Provincial Health Office in prevention and treatment. So right now I'm based in Chawama, but working in prevention overall, supporting all the districts that Siders and LPHO actually work in.
So
thank you.
Thank you very much. We have a very powerful team here, and they'll be helping us discuss and explore the issue of HIV PrEP. Thank you so much. I can see that we've been joined by a few more people. Thank you for joining us. We just want to remind the network that as we join in, let's quickly mute ourselves so that we do not interfere with the deliberations as the team are sharing. So without much ado, right now, I'm going to just share the slides and then ask Dr. Vlahakis and a colleague to run us through today's echo session. But remember, let's maintain the echo etiquettes. We mute ourselves. If we have a question, we put it in the chat box or we raise our hand, and then we'll be able to call on you to share. Dr. Vlahakis, please, you may take your stance now.
Thank you very much, Dr. Ziambo. Once again, good afternoon to the network. So today we'll be discussing PrEP as HIV prevention. So, and to kickstart, before we go into the nitty-gritty of this presentation, I just would like the network to give a few responses as we move forward. So if anyone on the network would be able to express or share if you've ever screened a client for substantial risk of HIV infection and what that experience was like, just briefly. If there's anyone on the network who would like to respond to that question, please go ahead.
So you can raise your hand and then we'll be able to just speak on you and then unmute you. So remember that ECHO is a platform for sharing best practices and learning from each other. So feel free to just respond to some of these questions as they set the foundation for the discussion.
So I'll repeat the question. Have you ever screened a client for substantial risk of HIV infection? What was that experience for you?
We haven't got anybody coming through to share the experience. So we don't have anybody coming through.
Okay.
Maybe they're still trying to get into the mood.
Sure. So we'll move on to the next question as well. Maybe that will help.
So there is a hand from Zaf Livingston. You can unmute yourself.
Okay, good afternoon.
Afternoon. Thank you for joining us, sir.
Sure, I would love to answer, just to give the few responses to these questions.
Please go ahead.
Yes, the first, have you ever screened a grant for substantial risk of HIV infection? Yes. Then the next one, or maybe I need to highlight a bit on the yes.
Yeah, please go ahead. That would be great.
Sure. So the clients that we've screened before, that's someone who is living with a partner, a discordant couple. Then at the same time, some people who are involved in risk behavior like prostitution, and the truck drivers, those who move, don't stay at home, that may need more than one partner. And then in your practice, what services have you offered to the client with substantial risk? As African Livingstone, we offer condoms, we offer VMMC, then we offer also PrEP, depending if one meets the criteria. Then if one were to think about HIV prevention, what comes to your mind? I think what comes to my mind is what measures or what things can be done to make sure we cut on the transmission of HIV and infection, HIV and AIDS. What things can we put in place that will stop that change so that we reduce or we completely eliminate the risk of others not getting the virus or not acquiring the virus? Then have you ever initiated a grant on PrEP? Personally, yes, I've done one or two. Thank you.
Okay, so thank you very much, Zaf Livingston. I think you've answered the questions in a way that really sets the tone for this presentation. The experience that you've shared is the experience that we find and that we have on the ground, and it's much appreciated. And so we will move on now to our next slide. So in this next slide, I'll share the objectives. So the objective is to discuss what is PrEP and why it is important to prioritize as part of prevention interventions. Our second objective is to describe the current state of PrEP services within Zambia and also the respective province that we support, and to discuss best practices in implementing PrEP. So to give a little bit of background, as Zambia gets closer to epidemic control, I'm sure you have all seen this surge towards HIV prevention becoming more cardinal or more important within the work that we do, in the facilities. Interventions like male circumcision, condom distribution, these have been offered for a number of years, but then with oral PrEP, we have seen that this has been an additional intervention that was included in the Zambian guidelines. But basically, the speed with which the uptake is at site level and within the facilities that we support has been not what we had initially expected. And so this drive in the past year, as well as the coming years, to scale up PrEP provision for individuals at substantial risk of HIV infection. So from 2019, the Ministry of Health, along with other supporting implementing partners, we moved towards aggressively scaling up PrEP for individuals with substantial risk. And you may have seen a series of trainings ongoing within your supported provinces and districts, as well as within mentorship visits. So you would find that there is a focus on PrEP and an emphasis on ensuring that we provide that prevention services to our clients. Next slide, please. So one thing about HIV prevention is that we need to recognize that an individual's HIV prevention needs might change during an individual's lifetime. You may find that an individual may have seasons of risk and they may need prevention services during that time, but they may have seasons where they're not so much at risk. And you find they don't use prevention interventions during that time frame. So it's important to ensure that we are providing an array of choice to our clients to be able to access the prevention services within our facilities. So combination prevention is a mix of both biomedical, behavioral, and structural interventions. And this decreases the risk of HIV acquisition, and we'll delve into that a little bit more in the coming slides. But ensuring that we are combining approaches enhances their efficiency, it provides greater impact than a single intervention for prevention. We do have antiretroviral drugs that are being used as PrEP, and it's important that we look at PrEP provision as an additional tool to the other prevention interventions that are offered. So we look at the structural, behavioral, and biomedical components of prevention. We have structural, which talks about the policies, laws within a country, the culture, the tradition, social cash transfers. All those are structural. And then we have the gender inequalities as well as structural. Then we have the behavioral, where we look at education levels, counseling, stigma and discrimination reduction, as well as risk reduction and behavior change, and adherence interventions as well, especially if one is on an intervention such as PrEP. For the biomedical, we have to ensure that as part of the package, we offer HIV testing, we offer condom distribution, we offer VMMC for the men, and EMTCT as well is part of HIV prevention. Treatment of STIs is also cardinal in preventing HIV acquisition if there's an STI identified. So antiretrovirals were also identified as being biomedical. So ART for prevention. So ART's prevention, which is now where we're providing, anyone who's HIV positive, we immediately initiate them on ART. PrEP as well as PEP are also part of the biomedical prevention methods. So why do we need PrEP? We already have several effective HIV prevention interventions, such as condom use, VMMC services, and HIV testing as well, which then, enables one to know their status and then decide if their social behavior would change. But most of the new infections that are happening amongst adolescent girls and young women, either pregnant or not. And it's important to target those populations with the appropriate prevention interventions, including PrEP. So in Zambia, we've seen 48,000 new infections in 2020. That was according to UNAIDS. But then also in the massive, we have seen that HIV incidence amongst key and vulnerable populations, such as adolescent girls, pregnant and breastfeeding women, as well as key populations, remains very high. And so PrEP provides that additional prevention intervention that we can use, together with other existing interventions such as condoms. PrEP is not meant to replace any prevention intervention, but as mentioned multiple times, it's an addition to what already exists. So we have one of the poll questions now that we would like the audience to respond to. So I'm sure it appears on your screen. And the question reads, the following regimens are recommended for PrEP use in Zambia except. So here we choose the one that is not recommended. So A, TDF 3TC combination, B, TAF XT3 XTC combination, and then we have TDF and FTC combination, and D, we have TDF 3TC and DTG.
Yeah, so thank you so much. Network, we invite you to participate. Which one of these following regimens are recommended? Except the following regimes are recommended for PrEP use in Zambia, except. So which one do you think is not recommended here? I know except feels like an exam. But let's participate. There's only about 48% of us that have participated. I'll give you an extra 20 seconds so that you can participate as well. Most people think it's D. A few think it's A, B, or C. But we'll learn today which one is actually the recommended PrEP regime. Okay, so we have remaining 5 seconds. Okay, thank you very much. I will end the poll now. And then let's see how we have performed. So if you check, you see that most people, about 75% of those that participated thought D was the answer in this particular case. So let's see as we continue. So Dr. Vlahakis, you can proceed.
Thank you very much, Dr. Ziambu. So in our next slide, we talk about why PrEP during pregnancy and the breastfeeding period. So evidence has shown that women may be at increased risk of acquiring HIV during pregnancy, postpartum, and the breastfeeding period, due to the same factors that we discussed earlier, either biological, social, or behavioral. And so we see that we have increased biological susceptibility amongst this particular population group, elevated hormone levels. So progesterone is dominant and associated with cervical inflammation. CCR5 expression increases as gestation advances. But this may also contribute to a pregnant woman's risk of acquiring HIV. And then we have changes to vaginal microbiome associated with genital inflammation and nutritional deficiencies as well. These lower immunity and untreated STIs associated with cervical inflammation. We have some behavioral exposures as well. So behavior changes in women and male partners during pregnancy or postpartum period. Quite often you hear about, the husband not wanting to bother the wife at home and, might go out to source, to satisfy their sexual needs. And less condom use, as well as intimate partner violence during this time. So how likely is mother-to-child transmission of HIV? European countries, and 43% in African countries. So effective HIV treatment and other preventive measures have reduced vertical transmission significantly, and Zambia is no exception to this. So optimum care, the transmission rates may go as low as 0 to 0.5. So it's important to be able to provide women with the best care possible. Next slide, please. taking PrEP who subsequently becomes pregnant and remains at substantial risk of HIV infection. It's important to remember that we should not stop PrEP for that woman, but continue with it during her period of risk, or at least during the time that she's pregnant and breastfeeding. A man, woman, or adolescent who is HIV negative and lives in a setting with high HIV incidence, so who is at substantial risk of HIV acquisition. And HIV negative key populations should always be offered PrEP. Next slide. The WHO recommends that oral PrEP containing TDF and or TAP combined with XTC should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination HIV prevention approaches. But we do have long-acting drugs that are still undergoing research or in the study phases, I would say. The dalpivirine ring, for example, cabotegravir, rilpivirine, these are largely injectables. And then islatravir, which is an implant that is being tried out in research settings as well. So we take a break from that and just look at what is it that we have in Zambia that our ARVs recommended for oral PrEP. Combined tablets of emtricitabine, so the FTC with tenofovir, daily, so that's the Truvada. And then a combined tablet of lamivudine and tenofovir, that's also daily. In some settings, you might see it as Tenolam, but quite often it just comes with the drugs named as they are. Combined tablet of tenofovir alafenamide, that's the TAF, along with emtricitabine. These are what are available within our settings. So the most common PrEP regimen tablet containing emtricitabine and tenofovir is the one that has been quite largely available. In the postpartum component of the PROMISE trial, something important to note is that there were no significant differences between TDF as well as those receiving, not receiving ARVs during that time of breastfeeding. TDF and FTC are secreted in breast milk at very low concentration levels. And in most studies around the world, it has shown that PrEP is safe in pregnant and breastfeeding periods. So there's no significant differences in maternal and infant outcomes. These were, between women who received PrEP and those who received a placebo in the VOICE study, meaning no significant adverse events during that time. And in 2016, WHO guidelines stated that there is no safety related rationale for disallowing or discontinuing PrEP during pregnancy and breastfeeding for HIV negative women who are receiving PrEP and remain at a substantial risk of HIV acquisition. Next slide, please.
Okay, so we have another poll. Maybe you could go ahead and read for us, Dr. Vlahakis.
Okay, so the next poll question reads, when is PrEP in pregnant and breastfeeding women not recommended? A, not knowing partner's HIV status. B, HIV negative pregnant and breastfeeding women with urine protein more than 2 classes. C, being in a discordant relationship. D, pregnant and breastfeeding woman who tests HIV negative and is at substantial risk of HIV acquisition. And E, pregnant and breastfeeding women having multiple sexual partners. When is PrEP in pregnant and breastfeeding women not recommended?
All right, thank you very much. So here we've got a list of things, and then we'll have a question. When is PrEP in pregnant and breastfeeding women not recommended? So dear network, please go ahead and pick your best answer. Is it A, not knowing partner's HIV status? Is it B, HIV negative breastfeeding woman with urine protein of more than 2+? Then being in a discontent relationship, breastfeeding women who test negative, HIV negative and is at substantial risk. Breastfeeding women having multiple sexual partners. So which person here, when is PrEP in breastfeeding and pregnant breastfeeding women not recommended? So far, we only have about 70 people out of 136 that have voted. We want some more people to participate. Go ahead and test yourself. Okay, so I'll end the poll now. I think we just about hit 60%. Thank you very much for participating. Most people think B is the correct answer. Some think it's A. A few thought it was E. So here's how we have performed. Most people thought B was the correct answer. Dr. Vlahakis, maybe is stupid.
Yes. So thank you very much for participating in the poll. We now will look at screening for substantial risk of HIV acquisition, and screening questions should be framed in terms of people's behavior rather than in their sexual identity, and should also refer to a defined time period. So as you're discussing, you say in the last 3 months, in the last 6 months, so that it's time bound. And it's important for PrEP providers to be sensitive, inclusive, non-judgmental, and supportive, and always ensure that we uphold confidentiality. When you speak about someone's sexual behavior in a public place, chances are they won't give out much information. So be careful not to develop a screening process that might discourage PrEP users. Next slide, please. So we have, listed on the slide, screening, what is the substantial risk of HIV acquisition in HIV negative individuals? And then what is the substantial risk of HIV acquisition when we are screening pregnant and breastfeeding women? So in the general population, a history of no or inconsistent use of condoms during sexual activity, which involves a client with a partner of unknown HIV status in the last 6 months, a client having more than one sexual partner, a client being in a long distance relationship, and a client in a relationship with an HIV positive partner. History of STIs in the past 6 months, and also clients that inject drugs or share needles. Important to note here as well is that, we stress on the fact that these are HIV negative individuals that we need to counsel during post-test counseling or screening for substantial risk. Yeah. And so when we look at screening for substantial risk of HIV acquisition in pregnant and breastfeeding women, it's important to note as well a history of no or inconsistent use of condoms during sexual activity involving everyone with a partner with unknown HIV status in the past 3 months. Anyone who's pregnant and breastfeeding or her partner having more than one sexual partner. So you'll find that quite often in our MCH clinics, women will come and say, I don't really trust that my partner is only with me. I suspect that he might have another partner, or I know that he has another partner. Pregnant and breastfeeding women who are in a long distance relationship are also likely to be at risk. And pregnant and breastfeeding women in a relationship with an HIV positive partner. Here again, we look at history of STIs in the past 3 months, and pregnant women that may be injecting drugs or sharing needles. Next slide, please. So we look at the eligibility criteria, and here it's the eligibility criteria is if an individual is at substantial risk of HIV infection and they test HIV negative at a health facility, there's no suspicion of acute HIV infection, there's no substantial risk of HIV infection, and their creatinine clearance is above 50 mils or proteinuria less than 1+, or serum creatinine that is less than 80 millimoles per deciliter for pregnant and breastfeeding women. Actually, it's pregnant and women in early postpartum period. And there's no risk of intimate partner violence. But with the risk of intimate partner violence, this shouldn't stop us from initiating or offering PrEP, but rather first ensuring that, you know, we screen every adolescent girl and young woman and every pregnant woman that we suspect with intimate partner violence and ensure their safety. So making sure that we provide PrEP for them in a safe environment. And this is, you know, it encompasses what would be our eligibility criteria. Next slide, please. So I'll pass on the next slides to Dr. Kabongo, who will go through the PrEP situation in Lusaka province and just share experience with what it has taken to scale up PrEP within the province, along with the Lusaka Provincial Health Office. Dr. Kabongo.
Thank you, Dr. Natalie. Good afternoon again. So I'm going to take you through the experience on the field. I think we've learned enough, a lot actually on what is PrEP, why we should give PrEP, but how is it like when you try to scale up PrEP now in your district or facility, province? So I'm going to share the experience for Lusaka. As Dr. Natalie mentioned, 2017, the guideline came, WHO recommended PrEP for people at substantial risk, and MOH really backed it up, and everything was put together in place to scale up PrEP. But up to somewhere last year or even 2019, numbers were still very low. So what we did is we conducted the root cause analysis just to identify what are the barriers to PrEP scale up, mainly in Lusaka province, but mainly in Lusaka district actually. So we collected data available in facilities. Actually, we chose 18 facilities in Lusaka. Facilities were chosen based on the daily attendance. So we chose facilities with maximum of 100 clients per day as high volume facility. So the data that we collected were analyzed, and that was the output there. It was categorized based on recipient of care factors and health system factors. So PrEP eligible clients actually were not even aware about what is PrEP. They had little knowledge about PrEP. Some were actually experiencing stigma, self-inflicted stigma, or actually stigma from other people just because they're using ARVs. Distrust and stigma from healthcare workers. We know most of things that we try to implement, the first obstacle is ourselves, healthcare workers. If we don't buy in, we don't believe in them, even the way we sell it to our clients, it's just with a negative body language. So that was also a problem. And some actually acknowledge that they were at high risk of intimate partner violence or GBV from their partners because they're taking PrEP. The health system itself, access to PrEP was actually a bit difficult. We talk about men involvement, but when you go to our facilities, you look at the client flow in MCH, it's very difficult to have men actually sitting there in MCH and supporting their partners and so that they can receive PrEP. And mainly, it's a low perception of HIV risk. Even among ourselves, trained, educated, we think we do it better. We think we know how to avoid the risk, especially that we keep on testing negative, I can say. So a lot of people actually felt like they were not at risk at all. So that was from a recipient of care. But the system itself, health facility factors, there's knowledge gap even among the healthcare workers about PrEP. This is not a situation that is in Zambia. Even when you go in developed countries, you see a specialist, an ID specialist, not really wanting to prescribe PrEP. Say, no, that's for an HIV specialist. So those things they happen even elsewhere. Lack of demand creation. We actually, if you look around yourself, you look at your facility, you're going to see very few posters or leaflets talking about PrEP. We had no reporting tools, incomplete data capturing in medical records, no dedicated focal point person at the facility just to drive prevention and interventions, no SOP, no screening algorithm, and mainly unfavorable patient flow. So about patient flow, I'd like to stress a bit try to visualize your facility. When do you give IEC? When do you test the client? When that client tests negative, is there any other screening or counseling being done now to give prevention to the same client? After you do the counseling, you give prevention talks about that. Do they go somewhere else where they are going to assess for eligibility and being put on PrEP? So those are things that were actually very difficult and still lacking up to now in our facilities. Next slide. So what we did to bridge the gap was we started by appointing a prevention focal point person at each facilities. We know we have that problem. We don't have, we still have very serious shortages on HR for medical personnel, but we just have to do it. If we don't think prevention now, we'll run out of resources of testing everyone and putting everyone on ARVs, which is very expensive for the government and not even very sustainable. We are not too sure what's going to happen if the government will manage to put more than 2 million or 3 million people on ARVs. So we have to think prevention. We started by appointing a prevention focal point person at facilities. We designed PrEP screening tool, which was lacking. We redesigned the PrEP screening registers and a PrEP register itself. We designed patient flow at facility to accommodate the service. So we know we do, when you come to our facilities, you have HIV high-risk screening in OPD. Once you screen positive or the counselor thinks that you are at risk of contracting HIV, they send you for testing. When you test there and you are negative, we are just lucky. You can still seroconvert next time that you come back to the facility. So from there, that's when now we want to start offering PrEP to everyone who tests negative, but previously screened positive for HIV. We raised PrEP awareness among healthcare workers and community health workers. We conducted several trainings. We did data cleanup. We categorized population. This is very important. I would like to stress a bit on who is a pregnant, who is adolescent girl, and who is in discordant couple. I'll give an example. If you receive in your facility a client who's 17 years old, negative, and the partner is HIV positive, and she's pregnant, how do you account for that client? Where do you put the client? Is she a pregnant, or she's an adolescent client, or you're going to account for her as a discordant couple? We also set target for sites. You can't work with that target. So this is the achievement for Lusaka province. So you can see the yellow line there showing that PrEP current. As we started in October, the PrEP current was very low, and we actually beat targets by the time we reached September last year. I'll show this in the next slide where it comes in terms of target and numbers. So this is just for illustration. Maybe let's go to the next slide to be more clear. Yeah, so in the next slide, you can see performance per district. This is for Lusaka. We have a PrEP target and achievement in blue there. The annual target for PrEP new at 5,955. By the time we ended the year, we're at 9,149, representing 154%. For our PrEP current, we are target 7,865. By the time we ended the year, it was 10,489, representing 133%. So this is for Lusaka district. You can see, follow the trend for the other district, and for overall of Lusaka province, target PrEP new was 6,369. We almost double that, 11,225, representing 176%. PrEP current was 8,430. By the time we ended the year, it was 12,815. This number looks amazing, they're green, but when you look at the number of people that we see who test negative in our facility, this target are actually very low. We can do better. I was doing an exercise in my zone in Chawama. I was trying to, I went through the HTS register, trying to account for the HIV positive, the people tested positive within a month. I came across, that was the month of July 2020. We had more than 30 positive for that month. And surprisingly, almost like 29 out of the 30 positive were actually given an HIV test within a year, and they tested negative. So this actually tells us, like, prevention methods, the pre-existing prevention method that we are giving, yes, they're effective, they're working, but we need something additional. We need probably to add, to push in PrEP to have it more effective, because people are still seroconverting despite us having VMMC and condom distribution doing great, actually. So what are the best practices? The best practices, so you have to design, we designed and the PrEP screening tool and push it into facilities. We start actually seeing that more clients were being screened after being tested. Ideally, we would want, when you're like in MCH, if you are going to have 100 attendants and maybe 10 are positive, the 90 who are negative, all of them should screen for substantial risk of HIV. So with the screening tool, that started happening. We appointed PrEP focal point person both in MCH and in OPD. I like to stress in OPD because when you go into a facility, you're going to see actually a lot of the PrEP champion is in ART. But look at it properly. In ART, we are dealing with positive clients already. So the client that we might capture, they are probably just discordant couples and maybe not a lot. The pool of negative clients, actually, they are in STI clinic, in OPD, in MCH. That's where people are still converting. So at facility level, what we advise is to have your PrEP champion in MCH and in OPD. ART is kind of self-driven. PrEP messaging incorporated into health talks. We want to make PrEP to be very loud, and the more we talk about it, more people get to know it. Weekly reporting and dashboard coverage. So now PrEP is being seen in our dashboards. Every Tuesday when we meet, we discuss about the indicator. Appointments and the tracking of clients. We don't have a system in place yet to know who's coming for PrEP refill next month and who has missed the appointment. We know for PrEP to be very effective, adherence is key. You have to take at least 95% of your tablets for PrEP to be 99% effective. But how do we track our client? How do we know this one is continuing on PrEP, this one has dropped off? So we developed a tracking and appointment register to make sure that we account for those clients. It's very important to redesign your patient flow to make sure that all negative clients actually are being screened and offered PrEP. We developed and utilized a screening register. It's also a tool that is helping. Capacity building through training and continuous mentorship, including the PrEP module in Smart Care. So the summary and the key points here. One, as we mentioned, PrEP provides an additional prevention intervention to be used together with the existing intervention. On this one, I would like to add that PrEP gives one power, especially women and adolescent girls. they can't probably, or if not, they can't, maybe it's difficult for them to negotiate condom with their partners. But with PrEP, one can choose how they want to prevent HIV acquisition. Key point number 2, PrEP is very safe in pregnancy and breastfeeding periods. Number 3, all negative individuals at risk of HIV acquisition should be offered PrEP as an additional prevention method. And 4, PrEP can be safely discontinued when one is no longer at risk. This is where the trap is. A lot of people shun PrEP because they think when they take PrEP, it's almost the same with being positive, right? But we know positive, we don't have cure yet for HIV. So you're going to take it for, let's say, for the remaining days of your life. But PrEP, once you're no longer into that season of risk, you can safely choose to discontinue PrEP. I think that's what we have for you. And the references are there. Thank you, Doctor.
Thank you very much. This is a very, very important topic. I've learned quite a lot here today. I hope the network has too. Yeah, I like the way it's put that there are seasons. Everybody has seasons in their lifetime for HIV prevention. And I think it's an important aspect that as healthcare workers, we need to pick up on. So before we take on any new questions from the network, may we just go through the poll question one more time? And we will relaunch so that Dr. Natalie can just take us through and see how we have done. So I hope network, you're still on with us and you're following, and we can participate in this poll question here. So this question says, the following regimens are recommended for PrEP use in Zambia, except the following regimens are recommended for PrEP use in Zambia, except. So meaning we need to pick the one which is not recommended here. And so far, we have how many? 32 have participated, and about almost all of them think it's D is the exception. Okay, so we'll give you a few more seconds. Okay, that's a minute done. Dr. Vlahakis, would you like to run us through this one?
Sure, so I'll take this one and Dr. Kabongo will take the next question. Basically, I'm happy to see that the performance has improved. Yeah. So we have learners that have identified the correct answers. And the regimens that are not, the regimen that is not recommended in Zambia is the TDF3TC and DTG, which is a full regimen for ARVs. But with TDF3TC, TAF-XTC, and TDF-FTC, these are recommended for PrEP provision in Zambia. In other countries, there are others to add, but for Zambia, A, B, and C can be offered, and the one that is not recommended is D. Thank you.
All right, thank you very much for that. I hope network we've learned something here. So the next 4 questions, I will relaunch it and share. Then we can all participate. Let's get ready with our questions or clarifications. I can see there we have some already in the chat, which we'll be able to share with our presenters today. So this question here is saying, when is PrEP in pregnant and breastfeeding women not recommended? When is PrEP in pregnant and breastfeeding women not recommended? Is it A, not knowing partner's HIV status? Is it B, HIV negative breastfeeding woman with urine protein of more than 2+, then being a discordant relationship, or pregnant breastfeeding women who test HIV negative and is at substantial risk, pregnant breastfeeding women having multiple sexual partners. So which one here? When is PrEP in pregnant and breastfeeding women not recommended? So far, we have most people think that B is the correct answer. That's when under these circumstances, it is not recommended. So, and it's over a minute. I will just end the poll and then share. Then I'll ask Dr. Kabongo to just run us through here. Which one is the correct answer and why?
Yeah, thank you very much. I can see there's also there's an improvement there.
Yes, there is.
Yeah, so yeah, it is B, which is not recommended. Because the PrEP regimen that we are using is TDF based. And once you have proteinuria more than 2 classes, you really have to screen further to know if it's just due to pregnancy or actually the kidneys are suffering. So you are in that circumstance, you are going to defer PrEP. You cannot initiate.
So in short, all these circumstances, PrEP is recommended. It can be given.
Sure.
Except, so the only reason here is that there's a kidney dysfunction that needs to be investigated. Thank you very much. I hope network we've picked up that one. Thank you very much for your participation. We appreciate it. Shows us that we have got people behind the devices that have connected in. Thank you very much. So I think at this particular time, we're going to respond to some questions. We have some questions in the chat box, but if you do have some questions, please, you can raise them. And I will ask Southern Province to get ready with making a presentation. We'll be turning to you in the next few minutes. You can let us know. So there's a question here, they're saying for the provincial, how did you come up with your provincial targets? Considering that most of them targets were above, the performance was way above 100%. So they wanted to know how you came up with your targets.
So on that one, I want to really go into details because it was calculated by MNE. Okay. As you can see, the first target was actually a bit low because this was like a kind of new scale up. Okay. But I'm sure for this year, we want to manage to beat this target easily. Yeah, okay. So targets actually were a bit underestimated by MNE when we started. This was just for baseline.
Okay.
And I'm sure at different provinces, MNE colleagues there should be able to provide targets to facilitate.
So maybe in addition to what Dr. Kabongo has mentioned, under the PEPFAR financial year, each province is provided with targets for key indicators, and PrEP is one of those. You'll actually notice that in this financial year, the PrEP curve indicator has changed slightly. And this in this year, what we will do is not have PrEP being just, adding on to all the PrEP new that we find each month, but rather we will also be subtracting those that drop off and may no longer be on PrEP. But basically those targets, yes, sit with the MNE team. In your provinces, ask them to check, what are those targets for your province that year, and then divide them by district. Quite often the PrEP targets may be lumped in 1 or 2 specific sites, but what they can do is then subdivide those targets and spread them out throughout your facilities. In some instances, you may choose very high volume facilities for the larger targets and then subdivide the remaining ones amongst your lower volume facilities. But in case there's any province that would like to reach out to have more information on how that was done, you're welcome to contact us, and I'll ask Dr. Ziambo to share our contact details in the chat. Thank you.
Thank you very much for that important response. There is another question here that, do we have TAF FTC on its own currently in our stocks?
No, personally, I haven't seen that combination. We know it's we can prescribe that for PrEP when we have kidney dysfunction. Mm-hmm. But what we have readily in our facility is either TAF alone or TAF with the DTG which is a tough age.
All right, thank you very much. Zaf, I've seen you've raised your hands from Livingstone. Please go ahead and mute yourself and you can ask your questions. IT, perhaps you could help with anything.
Okay, good afternoon.
Good afternoon.
Thank you. I have a question here. During the process of starting PrEP, it said for men, at least they should take for at least 7 days. For women, they should take at least 21 days. That's if they intend to get exposed to engage in something risky. Now, when ceasing, when one is no longer there, at what point how many days should one stop taking PrEP from the time the risk is eliminated? Is it right there and then, or there are a number of days that one should still take PrEP from the time the risk has been eliminated? Thank you.
Very, very important questions.
Okay, thank you. I'll start.
You are muted, we can't get you, sir.
Okay, sorry for that. So we have to acknowledge that the guideline currently used for PrEP is actually a bit old. So as we are in the process of developing a new guideline, we'll stick to what is there for now: 7 days for men receiving sex and 21 days for female. And to discontinue PrEP, the guideline says we have to take it for 28 days from the last sexual encounter. But what we know, the evidence now which are coming from different clinical trials or research is actually you can discontinue PrEP 2 days after the last encounter. So I don't know if you maybe we'll talk briefly about the PrEP on demand, which shows to be 77% effective. You take 2 tablets 2 days before and then 2 days after. So, but that is just, it's still, we are not using that guideline in Zambia, so it's just for this purpose. Don't preach about that. So evidence shows like even 2 days after last encounter, you can actually safely discontinue PrEP.
All right, thank you so much. Any comments to that? So there's another question here. They're saying in a discordant couple, when can PrEP be stopped? Or I think it's the same question. In a case where a pregnant breastfeeding woman or any recipient of care on PrEP finds the drugs are out of stock, is there an exception of giving a full ART that is TLD as client awaits the availability of drugs? Okay, so anyway, the guidance that we would like to give for these kinds of questions is that we need to be guided according to guidelines. So when we set out guidelines, we put a lot of things into considerations, and then they begin to guide our practice. And so, but as we move on, new evidence evolves, and then we have to sit again, look at them, and then review them and see if they meet what the current need is, looking at all the aspects. So far, as the guidelines stand, we will practice as we are guided by the guidelines, and that is to provide the PrEP in the way it has been provided. Until we revise the guidelines, that's when we will be able to consider other new evidence that has come to the fore. I hope that is very clear now for everybody, and that if drugs are out of stock, we need to avoid using regimens that are meant for treatment and using them for PrEP. because that's another, it will cause other sort of shortages and problems that may arise. So that's how we respond to that. All right, so we are 30 minutes to go, so we'll invite the case presenters to share their presentation. Are we ready to share? Or we can do it for you from here? Team Southern? Oh, great, thanks. Please introduce yourself to the network, and then you can go ahead and do the presentation. Thank you.
Good afternoon, everyone. My name is Sylvia Lunda, clinical officer general from Jasa Clinic, Southern Province in Choma. I'm presenting on a female, 27, now para 1, 6 weeks post-delivery via normal spontaneous vaginal delivery, booked at 21 weeks, 6 days, with no partner involvement. Client was screened for PrEP eligibility and was classified to be at high risk. She was pregnant and not married. Partner, HIV status unknown, and multiple sexual partner. She was initiated on PrEP same day and supplied for a month. During the second ANC visit, it was noted that she was not adherent to PrEP, as she was scared that her partner might discover that she was taking such medication. At 3rd month, she was retested and tested positive for HIV and was started on ART the very day, the same day. Delivered via normal SVD, birth weight 3.2 kg at the hospital, and baby was put on prophylaxis, AZT, 3TC, and NVP. DBS was done at 6 days and 6 weeks, and the results are still pending. Social life, single mom. Social life history, single mom, unemployed, multiple sexual partners, disclosed so far 2 partners, and those partners are non-positive, and they're less than 6 months on ART. Client stays with the elder sister. Drug history. Our client was given TD Health 3TC, which is PrEP, TD Health 3TC, which is TLD. She was also given INH, B6, CTX, and folic and Fellas. On physical examination on the 11th of November 2021, general conditions stable, no pallor, no jaundice, no cyanosis, no no horror thrush, chest clear. The BP was 128/80. Temperature was at 6 degrees Celsius. No paddle edema. Baby doing well and is on breastfeeding, and the weight is 3.6 kg. This is just a table that was simplified for us. On the 15th of June 2021, patient was tested for HIV, and the results were non-reactive. And the patient was initiated on TD Health 3TC, TD Health and 3TC, which is PrEP. On the 20th of September 2021, the client was tested, and the results were reactive. And she was put on TD Health 3TC and DTG, which is TLD. On the 4th of October 2021, VS was done on the baby, and the results are still pending. 11th November 2021, DBS was done on the baby again, and the results are still pending. So as a facility, we have some questions that we'd love to ask and hear from others on what they're going to say. So first question, how best could we have done how best could we have prevented this woman from acquiring HIV and AIDS? 2, how best can we keep this mother in care and ensure that the baby does not acquire HIV? 3, is the client at risk of developing TB health resistance? And if so, how best should she be followed up? Thank you, and have a blessed.
Very, very, very wonderful case and very clear. Thank you so much for sharing this presentation with us, Sylvia. Now we are going to ask the network to ask for any clarification questions. We are not answering these questions yet, but if there are things that you want to clarify about the case, maybe you need more information, then you can just take this opportunity, just raise your hand and then you can ask that question. I've already seen Kelvin Chishala wanting to ask a question. Go ahead, unmute yourself.
Thank you very much, Doc. Good afternoon, everyone. Yes, just a quick one. I wanted to be clear on 2 things. I will start with the same woman, the single mom. In the history, I noted that it was mentioned that the woman on the 2nd month, it was noted that she was not adhering to PrEP. And I've been told in the history again that she's a single mom. So, and the reason she was given there was that she couldn't adhere because she was scared that the husband or the partner would notice that she's been taking such drugs. So how is she classified a single mother in that case? Are they staying together with the same partner for her to be scared that that partner would discover those medications? Then the second one is, I've seen that the results from at birth of DBS and at 6 weeks were not, they are not yet in. I don't know what could be the problem in terms of having the results as quickly as possible for us to know the status of the child. Thank you.
Thank you very much. Jase and team, please go ahead and maybe respond to that. Those 2 questions.
Okay, thank you. So for the first question, whether she stays with the father to the baby. So the man responsible for the pregnancy is married somewhere else. So I can say she's a girlfriend, and they do not stay together. So they meet once in a while. And that is where her fear was, is once she goes with the medication at home, he might not tolerate it. I think, for this, that was into the second revisit. That's when she said she was not comfortable keeping such medication at home. And then for the DBS results, unfortunately, we have not received any results yet. And a follow-up has been made. Unfortunately, this time around, our turnaround time was a little bit long. So for the second one, we did it this very week last week on a Tuesday. So I think it's a little bit early. So we're still following up the one that we did at 6 days. Thank you.
Thank you very much for those clarification. Any other clarification questions that the network might have? If we don't have any, then we can attempt to answer these questions that Just a Clinic has put to us. So there's a clarification question from Kawe. They want to know whether the HIV test was repeated after 6 weeks after the first negative test. That is from Kawe. They want to know if you had a repeat test once after your initial test on the client. That's a question from Coward. And then the other question is that were the contacts for the client followed up for the HIV testing since statuses were unknown? Did we attempt to follow up the contacts for the HIV tests, for the statuses for the contacts? And then also, when was the second test, HIV test, done for initiation of PrEP? I think it's the same question here.
Thank you. So for the first question, I think during the second visit when she came at 4 weeks. 4 weeks later when she came for the second ANC visit. Unfortunately, the repeat test, we could not trace it on the file or in the registers whether it was done or not. So the test that the subsequent test, that is the one that we had at 3rd month, if that's the one that came positive. And I think, I don't know if for the other question.
So the other question was contacts for those that they're sexual partners.
Oh,
did we attempt to?
Yes. So she enlisted quite an. She enlisted only 2, but she said she had other partners, and she was not comfortable revealing them during that visit. Even the father to the child, she's still not comfortable mentioning who it is. But she promised she's still thinking about it, and then once she's comfortable and maybe have a side discussion with him, she might come with him at the facility. They have again a repeat test together. So they will have assigned a counselor to follow them up, and then just to provide. And also we don't want to force her too much because of that IPV risk that was noted. Thank you. So for the 2 that were followed up, was.
Thank you very much. That's clear. And it seems like there was actually a question, clarifying question, whether IPV assessment was done on this particular patient, client. All right, thank you so much. So I think at this particular time, with all the clarifications done, as we are heading towards the hour mark, I will invite for any comments now to just sort of respond to these questions. How best could the team have prevented this woman from acquiring HIV? How best can we keep this mom in care? We all can see that there are few risk factors surrounding this woman that we need to think about how we maintain her in care and ensure that the baby does not acquire HIV. And then, is there an issue of developing TDF resistance? So I think we will invite the network to make some comments. Do we have any people who would like to give a comment to respond to this question? And before we ask our experts on the panel, I can see a number of them. I've seen Dr. Animila, I've seen Dr. Msondabupe, I've seen Dr. Mamba. Who else? Yeah, there's even Dr. Lusa. Can't recognize some names, but I know there are some experts here on the call. But right now, we just want to hear from any of the facilities that are participating. What do you think? How would you have managed this patient as a facility? Do we have any comments, any takers? They are difficult questions, eh? You would also have the similar questions.
Dr. Ziambo, Jonathan.
Yeah, Dr. Njengama, welcome from Northwestern.
Thank you very much. I just wanted to acknowledge that these are quite very tough questions, especially the first 2. The last one is easy, but the first 2, I think what we could have done better And thanks, Southern, for that case. Indeed, these are some of the challenges I think that we are facing, where there is demand for the PrEP commodity, but then the social circumstances are not allowing for the individual to remain adherent. So probably thinking retrospectively, this may be a woman who was not ready for the PrEP given the social circumstances. And probably if we had cancelled her for condom use and the like, maybe. Because what I've noted here is that once people are given PrEP, they tend to throw away all other preventive measures. And some of the people who have come actually demanding for PrEP, they literally say, it could even be a married person. They say, I'm planning on some adventures somewhere, so give me PrEP. So the intention of the PrEP, I think more times than not, is for where someone intentionally, not that they are exposed, but they actually intend to get exposed. Thank you, Chairperson.
You brought out a very interesting aspect, Dr. Njengamwa, and thank you for sharing that. Indeed, people tend to throw away other prevention measures. I think the didactic was at pains trying to ensure that people understand that PrEP is to be used in conjunction with all other prevention modalities. Kelvin Chishala, I've seen your hand. You would like to make a comment as well?
Yes, Doc.
Go ahead.
Yeah, thank you. Maybe on the first two questions. The first one, I agree with what the doc is saying. From the case, from what I noted was that I think maybe we needed to give much information to this client on PrEP, like maybe how long did it take for this woman to take PrEP before starting engaging into the sexual activities with the same boyfriend, if I'm to put it. If maybe we had followed all those details, maybe they were followed, they could not just come out. And I think this case needed to be treated in a different way, in a special way, in the sense that since we've observed that the client seems to have some issues with the partner. Maybe the partner could be abusive. So maybe it is a situation where maybe a healthcare worker needs now maybe to bring in the other parties where they can come in and maybe educate this woman about her rights, so that this does not bring problems which we are facing right now. So on the second question, I still feel that for us to ensure that we do not have this problem of transmitting the HIV to the child, we really need to take the steps which maybe I've just suggested, Doc, in the sense that because I'm seeing a situation, if this woman is scared of that boyfriend of us to come and maybe find the same drugs, so we could experience the same problem even for the actual treatment, which will mean that she might stop when he's around. She would need to hide. And I think in this case, she cannot manage to hide because she failed to hide the PrEP drugs. So we really need to put in a lot of efforts in terms of counseling and making her realize the rights which she has. And we see how best we can connect her to some social care services where maybe she can be supported. It could be that she's lacking something which is making her go to that same man, maybe for food or something. So maybe we need to go to think maybe outside the box in those lines and see how best we can help this woman. Thank you.
Very, very helpful comments, Kelvin. I'll give an opportunity to CCH. I don't know whether that's Chipata Central Hospital. You have raised your hand.
Hello, good afternoon.
Good afternoon, thanks. Go ahead.
Yeah, this is Kaenda. So I think the previous commenters, they've preempted what we were supposed, our comments actually. So I think looking at the first question there, I think education, we didn't educate this woman. We didn't, give her that detailed information how PrEP works and the like. And this is the woman whom we are supposed to, not really to handle her like the way we handle other clients, but she needed some special care. And coming to the second one, this time, it will be difficult even for us to achieve adherence, because if we don't handle this case of learning from where we are coming from and where this thing is coming from, it will be difficult. So this is a woman where we are supposed to attach maybe, not necessarily a counselor, maybe with a healthcare worker just to be on her neck so that she's educated. I think this is what we can say. Thank you.
All right, thank you very much. I think even the team has seen that need. They've actually attached a counselor to support this woman. So one last comment before we run out of time. Shadrach, go ahead.
All right, thank you very much. Very interesting scenario here. Okay, just to give an answer to the first question, or just contribute a bit. Maybe, of course, this woman needed a lot of things like to be put in place. Like mostly here, as we have seen, like it was less than 3 months when she seroconverted. So which means also the issue of IPV pre-zero, as we know, so the dose of PrEP is once daily. Maybe we're also supposed to ask like the term that she's comfortable, since she doesn't know that the partner to know that she's taking these ARVs. Maybe we're supposed to ask like, okay, what time are you comfortable taking these medications, so that at least maybe your partner is not aware. Now, to this also, we may also have given the full information, but also, as we know that HIV has to do with the issue of window period also comes in, because we don't know, maybe the time that we tested the first test, she was still in that window period. And then after that 3 months, maybe she seroconverted, that's when the antibodies were picked. So that also comes in. And then on the next question, also second question, maybe sometimes as health workers, we just need to be proactive a bit. Because as we can see, they did the first DBS, there were no results. They also did the second DBS, which is at 6 weeks. Still, there were no results. But between the first and the second DBS, what intervention did the facility put in place? Like, did they try to follow up the results? As we know that most pediatric, in our care, mostly they are priority, knowing their HIV status. Maybe also in terms of providers, we need to be proactive. Thank you.
Thank you so much, Shadrach, for your comments, and we appreciate your participation in just contributing to the best practices and how we can manage and handle these cases. So I think I would want to hear views from experts as we wrap up this particular session. I've seen a hand from Dr. Zico. Please go ahead and mute yourself.
Thank you. Sorry, I dropped off the call at some point due to poor internet. I appreciate the contributions from the previous speakers. My addition is that even as we screen these patients for risk of HIV infection, we also need to pay attention to intimate partner violence. So we need to screen these clients for intimate partner violence, which is very important for them to be adherent to the treatment. So this is important not only for PrEP, but for ART as well. So we need to assess whether there are any risk factors for intimate partner violence and so on. Then the other contribution is that even as we screen for eligibility for PrEP, we need to also screen for acute HIV infection through the symptom screening. So I don't know if that was tackled, but if it hasn't been tackled, that is also very important, as you are able to at least have a high index of suspicion for HIV infection in some clients who may test negative for HIV with a serological test initially. Thank you.
Thank you very much. A quick comment from Dr. Wupem Sonda, if you can hear us on the call.
Thank you, Dr. Ziambo, and good afternoon, everyone. And thank you, Dr. Vlahakis and Dr. Kabongo, for the very enlightening presentation and for bringing out all the pertinent issues that pertain to PrEP. My only comment, in addition to what everyone else has said, is just like Dr. Zico, to also pay attention to changing perspectives of our risk perception, because maybe what was not deemed risky at first changes over time. Even the behaviors that she had with the partner, maybe before they were using protection or barrier methods of prevention, and now the relationship has changed. So part of the counseling should also strengthen around one's perception of them being at risk and whether this has changed over time. And I think, as he mentioned earlier, the emphasis on intimate partner violence that we often neglect and do not pay attention to. But, and then also, we also just have to be sure that the client is ready to take it. And when we say ready, not just about I'm ready to start today, but are they willing to adhere, and will they feel the same way about it tomorrow and the next day, be willing to come back for reviews? That also comes into perspective, because I think starting is not a problem because someone just feels I'm at risk, I need this, I need to protect myself. But am I willing to walk the talk and go the extra mile to stay this way? And I think those are some of the issues that we need to think about as we go around offering PrEP to our clients. Otherwise, all in all, and thank you so much for the great presentation, Dr. Natalie and Dr. Kabongo. Thank you.
Thank you very much. I think in wrapping up, I'm going to ask the team here just to sort of give a response to some of these questions.
No, thank you very much. And thank you to the Southern Province team. I think you've chosen a fantastic case, actually, because it allows us to highlight a number of the issues. So part of, most of the question, I think, has been answered, key issues around educating our clients on the importance of PrEP. So, why should an individual be on PrEP, helping them understand benefits to themselves. And in the case of a pregnant or breastfeeding woman, understanding the benefits to the child as well. So that part is extremely important to highlight. And then, just tips from the field, what we've done in some instances when a woman doesn't feel safe to go home with PrEP, or any individual, but especially pregnant and breastfeeding women, we have repackaged the PrEP drugs in a pill bag and called it just part of the prenatal tablets they're supposed to take until they're ready to disclose that to their partner. And we work with them through continuous counseling by either provider or counselor until they're in a safe position to be able to explain to their partner. But once they've understood and they've chosen that they would like to be on PrEP because they're at risk of HIV acquisition, those are just some of the ways that facility-based staff have been able to go around dispensing of the PrEP drugs themselves. One issue that has really been touched on is IPV, and I'm glad that it came out through these discussions. But what do we do once we've identified IPV? And one thing that we need to note is that we need to enhance safety of that individual. So provide them with the first-line GBV support, which is commonly known as the lives first-line lives provision of GBV care, where we listen. So the lives is actually an acronym. L is for listening to the individual or our client. I is inquiry, so inquiring a little bit more, and really inquiring about them, being non-judgmental, validating what it is they tell us, because they're probably in a position that is really risky. and we don't really know how to ascertain what level of risk they're at, and then enhancing their safety and providing support. But that's, you know, a whole discussion for another day, I would say.
Yeah.
But, you know, important to note that even once we've identified IPV, there are things that we can do. There is a service that we can provide, you know, from our smallest facility onto the larger ones as well. And I like the fact that it was brought out that the chances are that this new mother is still at risk of HIV acquisition because, sorry, not HIV acquisition, but it's still possible that she's not adhering to her ARVs because she still feels at risk of IPV. And so it's important to engage with her as a facility, call her back and try and understand a little better what is going on and try and help her through that process to enhance her safety. Her baby still remains at risk, I would say, because she's probably breastfeeding. And so engaging with her and ensuring that you know, she's taking her ARVs correctly is important. From my end, I think that would be it, Dr. Ziambo.
All right, I don't know if Dr. Kabongo, you're adding any.
Just 2 words, I think, adherence and having a focal point person. If there's someone at least knowing that she's late for appointments, let's go and find out what is happening at home. Because PrEP can be dispensed even in a community once the retest is done at the facility. The first test, the second test, the rest we can take it to community level. So adherence is very important. Like, unfortunately, she's seroconverted. And we need really to push more focus there.
All right.
Thank you.
Thank you very much. Njase Health Center, are we okay with the response given to you so far? Njase.
Thank you so much for the responses. We've noted all the answers, and in where we didn't do well, we promise to improve. Thank you very much.
Thank you very much, Njase. You have actually done a great job by bringing up these cases because we are struggling everywhere. You're not the only one. And so this has given us a platform to learn from. So thank you very much. The rest of the network, we are happy that you joined us. Kazungula DHO, I can see you. Also, Madzimoyo Rural Health Center, Chipata, thank you for joining us. Banda Gertrude, Mshawa, thank you for joining us. We have come to the end of the presentation, and we say that you may have a lovely week. We'll see you next week. Bye.